We'll be covering the hip, and we'll be referring to the right hip, viewing it anterior aspect. With the hip, we're going to put this in quotes because you really aren't clear exactly where the location of hip pain is. That's the first step, is to get clarity about where that pain is located. So I'm going to draw the iliac crest. We're going to include the sacroiliac joint. We're going to go down here to where we have the femoral neck, the greater trochanter, the femoral head and the acetabulum, the sit bone, inferior pubic ramus, coming over superior pubic ramus, the obturator. So there's our anatomy. Say the patient comes in with hip pain that's localized in the mid-coronal plane at the top of the iliac crest, right here. Well, we should add some more structures here. I'm going to add the femoral condyles and the tibial plateau, as well as the fibula. So we do have a structure that attaches here at the ilium and to Gerdy's tubercle on the tibia. That's the iliotibial band. Along its path, it can create another site of hip pain by rubbing on the greater trochanter. And just to be complete in discussing the knee, when we have rubbing of a friction type of irritation occurring at the lateral femoral condyle, we can get snapping knee syndrome. And finally, the last spot of pain of the ITB is at Gerdy's tubercle. These 2 points of attachment can undergo repetitive tension, creating an enthesopathy. And that's how you can get pain localized to the 2 extremes. These other 2 points, pain can be created by friction in ambulation, where the IT band rubs along these bony prominences. A first step that we should take in evaluating this structure as being the source of pain is to see how tight that IT band is. And for this, we have the Ober test. So I'm going to say it's really a test for the tension in the iliotibial band. We want to assess ITB tension. With the hip and knee in extension, this band is on its maximum stretch. When you bend the knee, you create slack. It actually glides posterior to the femoral condyle. And when you flex the hip, it actually creates even more slack as it glides anteriorly. So for this reason, when it's inflamed, when one is seated for a while, it will tend to tighten. And it's when a person gets up and begins to walk that tension is occurring at these 2 attachments, and that's when the patient has their pain. So that's a symptom to listen for in the history. We're going to apply some of this during our Ober test. So let's have lie down on the side. We're going to be testing the hip that's upwards on the top. And you want the pelvis perpendicular to the table. And you want to create maximum slack. So you want the knee flexed, you want the hip flexed, and you're going to scoop that leg, and you're going to AB duct, creating even more slack. This hand is going to stabilize that pelvis so the patient doesn't roll back as you extend the hip, and you are producing you're introducing tension along that IT band. Enough that you can assess by now, not losing your extension at the hip, you're going to allow that knee to go to the table. Now this leg is being suspended solely by the IT band. Normally it should be lower, so yours is tight. And you can even palpate the IT band's tension. Okay, that's the over test. Thank you. All right. Also, in putting tension through there, the patient may have their pain at the greater trochanter reproduced. So the over test, let's put this here. The source of pain being the IT band. We do the over test. We also have underneath the IT band trochanteric bursitis. Little blue stands for the bursa. It's right here. If there's some debate now as to whether there is even a bursa there. However, this is a point for friction irritation, and often corticosteroids are administered to cool that down. The next source of hip pain that I want to draw your attention to is mid-inguinal pain. The inguinal ligament attaches to the ASIS, from the ASIS to the pubic crest. Mid-inguinal pain is right in this region. And you'll notice it overlies the femoral acetabular joint. That's true hip pain. Just call that mid-inguinal pain. Underneath this category, we can be dealing with true hip joint pathology. And an example of that most commonly is DJD. It can also include a labral tear. It can include avascular necrosis of the femoral head, all of those. Avascular necrosis, and I'll just leave it at that, ... So an important test to include when evaluating mid-inguinal pain is the Faber test. Faber is not a person. It actually is composed of the letters that form the position you put the hip in. You flex it, abduct it, externally rotate it, and extend. What that does is it loads into the fibers of the hip capsule and drives the femoral head into that acetabulum. So I'm going to demonstrate that. Rather than going through the effort of passively bringing the patient's leg into that position, you can simply ask, can you put this leg down? Make a figure of 4. So she's flexing, abducting, externally rotating, extending. If she can do that passively with full range of motion and no pain, great. Pain is the main symptom you're looking for. We do have people with capsular tightness that have difficulty getting into this position, but since it's painless, it can be just due to capsular tightness and not to DJD. Once again, it's flexion, abduction, external rotation, And the knee back to the table is extension. If they have pain with that, send them for an x-ray, hip x-ray series. You can also compress along the long axis of the femur right into the acetabulum and roll around that femoral head in the socket and see if that produces pain, to give you an idea as to where their pain is located. Just stay right there. I'm going to go right to the next one. So here we're going to say, if pain, go to x-ray. Now, the other pathology is the labral injury. And that, you would want to flex a deduct and internally rotate. So we're going to flex, a deduct, keep your hand on the knee as a fulcrum, and internally rotate. So you're really compressing the area of where the labrum is most commonly injured, which is along the anterior and superior margin of the acetabulum. Okay, thank you. So that's pain in the mid-inguinal area. Less commonly, I'm going to mention 1/3 etiology for pain located in this area, and that is the iliopectineal bursa. We actually have a little bursa here. I've only seen it in about 5 patients in my career, but I'm going to include that in my list here. Most commonly, the Faber and the Fadir test are negative in iliopectineal bursitis. If you suspect it, an ultrasound will readily reveal that. You can go send them for an ultrasound, and it'll show the fluid-filled bursa. Pain localized here. The SI joint is often called hip pain. So, SI joint pain. This is an enthesopathy, often due to the little ligaments that cross this joint or stabilize it. And what we should do first is get our hands on the patients posteriorly, find those iliac crests. Know that they terminate medially as the PSIS. See if you can get your fingers on the PSIS. I'm going to draw a sacrum in here. So when you palpate, you can find the PSIS and glide your fingers medially. You will actually be right on those sacroiliac joint ligaments, and the patient would be able to verify if that is where their pain is located. I like to use the sides of my hands, put my thumbs here, and glide medially. And we're going to do 2 tests to assess if one of these is restricted. So I'll list what those are, and then show you how to do them. So the first of all, if you have pain localized to the SI joint, that is termed sacroiliitis automatically. That's part of your diagnosis. Secondly, test for restricted SI. I'm going to give you 2 methods. One is standing. You do the forward bending test. which requires that you have each thumb at the inferior aspect of the PSIS. The patient bends forward all the way at the waist, and you expect the lumbar spine to flex, followed by the sacrum, and then the ilia. If there's a restriction, the ilia will move with the sacrum prematurely because there's minimal motion between those two bones. So in that case, that side will move first or forward, the side of the restricted SI. So side of SI restriction moves PSIS, moves first or farthest. Alternatively, you can do a supine test, which I will describe as compression. Sorry. It's a compression test where you're testing out flare of each ilium. Which will be a function of the mobility in the SI joint. Let's go ahead and have you stand right here. I'm just going to show localization of your sacroiliac joint. So I'm going to come to the waist, and you can see the two dimples here. Those overlie the PSISs. They're a great aid in localizing the SI joints. Normally I bring my inner aspect of my index fingers here, and the thumbs will hang around that. So that's right where her PSIS is. Now I'm going to go ahead and ask her, do you have pain on the right?
Yes.
And on the left? Well, she does.
On the right.
On the right, so sacroiliitis. Let's back up toward me a little bit so that we don't run into the wall there. I want you to contact the inferior part of the PSIS. Bring your chin to your chest and continue bending as though you're going to touch. Yeah, watch my right thumb. Okay, you can stop there. So you can see my right thumb moved first and farther. Okay, let's have you return. So she has a restricted right sacroiliac joint. So I'm going to have you lie. You can lie that way. Put your head here. No, face up. There we go. Oh, face up.
Face up.
So what we want to do is contact her ASIS. Remember, the ilia converge from anterior to posterior to the sacroiliac joint, like that. So when I contact her ilia, I'm going to compress in that very direction. If you can see, my forearms are kind of pointing in a line parallel going to SIs. Now I'm going to hold one and gently try to outflare like a book on its binding. You're trying to open the back page, actually on the left. Okay? And then I'll compare it with the one on the right. And my experience with her is consistent with the forward bending test. Her right ilium is resistant to outflaring. And that's because the sacroiliac joint on that side is restricted. So both of these tests, one may be a clear test when you do it on your patient. They both may be consistent. So I advise trying to do both in evaluating the sacroiliac joints. Okay, thank you. One more area of pain that we see that's described as hip pain. I need to put some lumbar vertebrae in here and some transverse processes. And what we're going to do is consider the patient who has inguinal pain. It's sort of kind of like in this area, it's lower than the mid-inguinal area. It's growing pain is a better term. So if you consider the muscle that originates in the iliac fossa, we're thinking about the iliacus muscle attaching to the lesser trochanter, and it blends in with the fibers of this other underappreciated muscle that attaches to every transverse process, every disc, every vertebral body of the lumbar spine. And when I get enough lines here, I've actually drawn pretty much most of the muscle in there. It is the psoas muscle, iliopsoas. Patients who have extremely tight iliopsoas muscles experience pain as growing pain. You can strain this muscle, so have a primary stretch injury to it, and it would cause pain. It's also a compensatory muscle, so if there's any instability in the pelvic girdle or in the lumbar spine, that muscle just fires up, and patients can't raise their leg to get in the car, they can't raise their foot to put their shoe on. That muscle is tied up. So we have ways of evaluating it. One is called the Thomas test. Let's put this muscle in our list here. So is muscle tightness or spasm. And the Thomas test is a comparison of hip flexor contracture. And so what you need to do is compare each side's hip's ability to extend with the lumbar spine flat. That's all. Those are the two main steps. So I'm going to have you come, and we'll have you lie that same way. Very important to have both knees bent and just comfortably. Then you can check